that exercise doesn't help everybody in type 1. Some people respond and get some improvement of insulin transport into the muscles, but a lot of people don't see any improvement at all in type 1. With type 2 is non-insulin deficient, bless you, and is considered more lifestyle based, right? There seems to be some genetic underlying factors for some people, although that isn't clear in the literature because it might just be that family members have a similar lifestyle and eat similar types of food and don't do sedentary activities together. So it's not absolutely clear what role genetics plays in type 2 development. In type 2, we have a pancreas that works and does develop and does produce and secrete insulin. But what happens is that the muscle membrane and the liver become less sensitive to the insulin. So the same amount of insulin results in less glucose moving out of the bloodstream and into the tissue. So that then leads to an increase in blood glucose levels again. So we get the same measurement, we get high blood glucose levels, but by a different mechanism for a different reason. When you look at adults, about 85 to 90% of people who are diabetic are type 2. In children and adolescents, that's not the same case. In children, most diabetics are a type 1, but we are seeing an increase in the levels of type 2 in younger populations as well. So that's concerning. Used to be only adults that develop this disease. Now we see teenagers being diagnosed as well. So also for children, girls are more prone than boys. I suspect, I haven't read that literature, but I suspect because girls are more sedentary than boys. But in adults, sex doesn't play a role. So males and females are equally at risk of developing the problem. People with diabetes, type 2 diabetes, can go blind, have kidney disease, they have vascular complications that can put them at much higher risk for cardiovascular disease. So it's pretty unpleasant. Some people say that it's an epidemic now. We certainly have seen a very sharp rise in the incidence of it over the last 20 years. So it's not good. Risk factors, obesity is a risk factor. Lack of exercise, so sedentary behaviors. You do see more people diagnosed at older ages, so age makes people at more risk, but generally that's because as we get older, we eat more and we exercise less. Right? It may not be age per se, but the lifestyle we choose as we age. Ethnicity does play quite a big role. So Native Americans are at more risk than African Americans. They're at more risk than Hispanic. But you see, it's not like there's a population where you don't get type 2 diabetes diagnosed now. Right? Every population is seeing increases in the problem. So the controllable risk factors, obesity and lack of physical activity. So when you look at obesity, adipose tissue, particularly visceral adipose tissue, so the stuff that's wrapped around my organs, here in my trunk, rather than the type that's under my skin, the subcutaneous. So visceral fat is a bigger problem because it releases a substance that destroys the beta cells in the pancreas. So then the pancreas starts to struggle with producing enough insulin. Also, fatty acids that are released from both types of fat, but visceral fat is much more prone to release its fatty acids into the bloodstream than subcutaneous fat is. So you release the fatty acids, they travel to the liver and the muscle in the bloodstream, and when they get there, they blunt, they drop down the tissue's response to the insulin. And so now the insulin can't transport the glucose out of the bloodstream. It's estimated that by losing 7% of your body weight, you will see up to 50% improvement in your insulin sensitivity, so your ability to move glucose out. That's a pretty big payback if that study is replicated and shown to be consistent. That's a huge payback for not a lot of work, right? So that's going to be a very important line of research while they try to confirm that and look at what the mechanisms are and that kind of idea. When you're looking at physical activity, then muscle contraction, so this gets a little bit technical. Don't worry so much about the technical stuff. Muscle contractions stimulate the removal of glucose from the bloodstream into the tissue in a similar way to insulin. So the more muscular contractions I have, the more the insulin is able to move into the bloodstream. Okay? So they've seen that response for up to 48 hours post-exercise for some people. Again, I haven't read this particular research. I suspect the length of time will be individual, but it may be tied to how hard you're working. Perhaps it's tied to intensity. I'm not sure. Long-term training. So we see an acute scenario on that day, but you also see long-term training improvements in how well we're able to move glucose out and a drop in blood sugar levels. So exercising, actually doing repetitive muscle contractions has shown to be very beneficial. Typically, people have said aerobic exercise is more beneficial because it's repetitive, but actually recent research is showing that resistance exercise works as well. So I can combine both, or I can do one or the other. Right? So I don't have to produce as much insulin if the muscle contractions are doing some of the job. Does that make sense? Right? If you want to get technical, GLUT4 is the transporter across the membrane. Insulin uses GLUT4 to move sugar out, and muscle contraction stimulates GLUT4 transporters. So if we can get someone who has type 2 diabetes onto a regular exercise program, help them to lose body weight. Remember that if I'm looking at losing fat mass, I want to be looking at that fat zone. Okay? But if they're obese, you're not going to be able to get them up into that fat zone safely for a while. So you've got to do the pre-training in order to train idea. Right? So we're looking at time. I can't just lose weight in 2 months. It's going to take a year, 18 months, because I've got to get them fit enough to be able to really attack the fatness problem. So type 2 diabetes then responds very well to exercise. Many people can use physical activity to treat their disease. So instead of having to resort to taking some form of medication, by being physically active, they're able to keep it under control and keep their blood sugar levels relatively stable. They're even starting to show that it can prevent type 2 diabetes from developing in at-risk populations. So, again, what are we doing with our children? What are we teaching them? How do we get adults engaged? Why are we cutting PE and recess? When we know this, there is so much research to support PE and recess, and yet it's getting cut left, right, and center. It's insane, right? You guys are going to go out into the wide world, and you're going to get the opportunity to vote. Use it wisely. Someone is saying, oh yeah, we're going to get rid of PE so the kids can spend more time doing math and score higher. Don't vote for that person. That would be very bad. Right? So, activity supports the sensitivity of the muscle membrane to insulin. It reduces hypertension. It improves body composition, drops blood lipid, right? All the things we've talked about, all the positives about exercising on the vascular system and the heart. And it's estimated that it decreases the risk of death from cardiovascular disease as a result of diabetes by 50% or more. So if we can get diabetic populations moving on a regular basis, get them into an exercise program, then we're going to really significantly impact their quality of life and their longevity. So aerobic exercise, as I said, because of the improvement in the sensitivity due to the impact on the transporter, that's looking like maybe lasting up to 2 days. That means that we don't want too big a gap in between our exercise days. So we want to encourage them to do aerobic exercise every day if you can, but at least every other day, right? Because we've got to top it back up again. It's not a permanent response. So we have to top it up every couple of days for them to maintain the benefit, all right? So neuropathy occurs in many people with diabetes. Because of the high sugar levels, it does nerve damage, and then we see decreased ability to sense where their center of gravity, where their balance is. So with some diabetic populations, you want to be careful with doing things that are going to put them off balance a lot. You need to know your person very well, right? For some people who may have already developed neuropathy, then non-weight-bearing swimming, cycling type exercises might be a better choice for them because they'll be at less risk of falling in that scenario. Right? Intensity, depending on how overweight or obese they are, you may have to drop your initial intensity. This is what I say about pre-training. Right? I'm going to have to pre-train them to get them to the level where we can do the real work. So you may have to go down as low as 40% of their VO2 max. You might only be able to do 10 minutes at 40%. Right? That is not going to help them lose weight. Okay? But you don't want to give them a heart attack, so we're going to start really low and build it up gradually. We want to get up to around somewhere between 50 and 70%, depending on what the goal is. You don't want to go into those high intensity ranges. Right? If they're wanting to lose, if they're needing to lose fat mass, then remember at some point the goal is going to be a minimum of 30 minutes at an intensity that will utilize stored fat as an energy source. With resistance training has now been shown to help move sugar out of the bloodstream as well, and obviously increases muscle, and that's beneficial to their quality of life. We see increased carb storage within the muscle, so glycogen storage improves. That helps them day to day. The ACSM and the American Dietetic Association have slightly different recommendations for resistance training. The Diabetic Association suggests a little bit more than the ACSM does. So you're probably looking at a minimum of twice a week if you can, but that's the same for all populations. Everybody should be doing some resistance work twice a week, not just people with diabetes. So they're not dramatically different to a healthy population. Questions on diabetes? Alright, so the next one I wanted to talk about was metabolic syndrome. Remember, I'm kind of picking the ones that I'm discussing with you. Try to look at the whole chapter. Alright. Metabolic syndrome in Europe is known as syndrome X. I haven't heard it called that over here. But certainly at home, we don't use the term, we didn't, when I left, use the term metabolic syndrome. It was syndrome X. And metabolic syndrome is a grouping of problems that are interrelated, and when you see them grouped together like this, it increases your risk of developing further problems. So obesity, hypertension, a poor blood lipid profile, so what are my LDLs versus my HDLs, right? What are my triglycerides like? And the beginning of insulin resistance. So people with this grouping of conditions are at least double the risk of death from cardiovascular disease, right? 9-fold increase in their risk of developing type 2 diabetes because they're already on the way, right? So if you can't stop the progression of these, then they're gonna run right into type 2 diabetes. And can't remember where I got the 23, but the textbook actually reports the 2006 National Health Survey figures as 34%. So I'm not sure if the 23 is more recent and we're looking at a better picture, or whether it's old and the picture got worse. I suspect it's old and the picture got worse, to be honest. So metabolic syndrome, we're looking at this grouping, or at least 3 of the 4. So again, visceral fat is more of a problem than subcutaneous fat. So people who, when they put on weight, go apple-shaped rather than pear-shaped, right? So more often men. My sister's a classic apple, so it's not that you're not going to get women who go apple, but women typically go pear. The weight goes on here, not here, right? But that's not everybody. The insulin resistance, so obesity is the primary bad guy in the grouping. Insulin resistance often follows from the obesity because of the fatty acid problem. And then people who are sedentary are twice as likely to develop the grouping of characteristics. So being sedentary again proves to be not a good lifestyle choice. You don't have to do formal, strict, heavy exercising like you guys do. Right? Remember, we're talking physical activity. Doesn't have to be formal exercise. How can we get people active who don't like sport? Because whilst that's difficult for you to imagine, there are people out there who don't like sport, right? So how are we going to do that? How are we going to tackle that? Age does play a role. Diet, so particularly people who eat a diet that's very high in carbohydrates, right? So we said carbohydrates should be somewhere around 50%, maybe 55 if I'm somewhat active. We don't really want to be going higher than 55 unless we are training hard, right? Which is not most of the population. So once we're looking at more than 50% of my diet is carbohydrate, then you're starting to put yourself at risk. Can you change up your diet? So then we've got to try to get someone's weight down. We want to reduce their calorie intake. They're probably, if they have developed this problem, they are not eating 2,000 calories a day. Probably. Right? So can I reduce their calorie intake? Remember, we've got to shift the seesaw, right? By 500 calories a day. Can I shift the seesaw by 500 calories a day? If they're really taking in too many calories, you could cut their calorie count down by as much as 1,000 calories a day, depending on the individual, right? What's the real picture that you're looking at? There's obviously the opportunity to use those carbohydrates as fruits, vegetables, whole grains, not simple sugars. I don't want to be eating a lot of candies or jams or certain kinds of fruits that are very high in sugar and not very high in fiber. Right? I want to, again, do this weight reduction over a long period of time. This is lifestyle. Right? If I'm going to make a lifestyle change, if I'm going to encourage someone to change their lifestyle, changing any habit, developing a new habit, according to the research, takes a minimum of 12 weeks. Right? Any habit, doesn't matter what it is. So, I can't do this in 8 weeks. Right? We want to look at 6 months, 12 months, 18 months, over time. Can I teach them a different approach to their health? Restricting carbohydrate intake may be effective for some people. We want to try to get them doing some physical activity, particularly if we can get them at least starting with aerobic work. We don't want to give weight training to someone with high blood pressure, right? Because weight training increases blood pressure a lot. So if I'm dealing with someone who's overweight or obese, then initially my exercise plan wants to be aerobically based. Right? And then we add the weight training or whatever type of resistance work we choose once we've got them on the path to being more healthy. And here's part of the problem. Okay? This is the picture for children. So the last lot of survey data was reported in 2009, so we should have some new data pretty soon on the 2003-2006 period, and look at the increase in obesity since 1971. Right? So this is 2 to 19 years, so this is not adults, this is children. If I am overweight at 8, I have a 60% chance of becoming an overweight adult. And we're not looking at overweight, we're looking at obesity in this chart, right? So these children have very little chance of becoming healthy adults and a very big risk for developing type 2 diabetes, cardiovascular disease, and all the rest of it when they hit adulthood. Right? And this picture is not improving. There's some data recently to suggest that it's stabilizing a little bit, but it's not improving. So stabilizing, I guess, is a good start. I suspect we're stabilizing at higher percentages than in 2006, so that's not good. Metabolic syndrome was, again, like diabetes, considered something that you identified in adults. But in October 2007, the International Diabetes Federation held a workshop with experts on obesity and diabetes and metabolic syndrome, trying to look at how we could define pediatric metabolic syndrome, because if we can't define it, we can't identify it. And if we can't identify it, then we can't catch it before it develops into type 2 diabetes, right? So they wanted to be able to have a validated list of characteristics that they could use with children to say, okay, they now have metabolic syndrome and they're going to develop type 2 diabetes if we don't intervene and do something about it, right? So what they came up with, and this is for children who are over 10, or 10 and over, I suppose. So we don't have it for young children, but for older children and adolescents. We've got 10 to 16 years, clustering of any three of the following. So obesity, where their waist circumference is equal to or greater than 90% based on their age and gender. So if they're at the 90th percentile for their waist circumference, remember it's the visceral fat that is a bigger problem. So if they're at the 90th percentile or higher for their waist circumference, for their age and sex, that's one of the characteristics. Triglycerides that are higher than 150 milligrams per deciliter, that's very high. HDL cholesterol, that's the good one, less than 40 milligrams per deciliter. Right? Systolic blood pressure, this one scares the pants off me. Systolic blood pressure greater than or equal to 130 over diastolic pressure that can be greater than or equal to 85. Right? So you're looking at a 10-year-old, possibility of a 10-year-old, they've had to use this classification, 130 over 85. It's not good. All right. For individuals over 16, they've decided that the adult definition for metabolic syndrome should be used 16 and above. So the fact that we even had to think about defining metabolic syndrome for children is scary. So it's a really poor picture right now, and you guys are going to be the ones that can go out and change it because you're the ones with the education, you know what to do, you know what needs doing.
But like in schools, like we get the education to go in schools, but what if the curriculum not in school? Never mind. It's
I know, but that I don't. Can you start after school clubs? Can you work with your local rec centre and get the kids involved in your local rec centre? I absolutely agree. If the curriculum doesn't exist, what do? You're going to have to find another way.
just give up.
You can't give up. You cannot give up. It's not a good picture. Those kids need you. All right, so someone else for ADHD. I think that's a good plan because you've got quite a large number of children that you're going to come in contact with who are diagnosed with ADHD. And these are the ones who are diagnosed, and trust me, getting parents to take their kids to get tested is problematical. So I suspect we're looking higher than that because parents don't want their kids labeled, because once they're labeled, then they become a troublemaker, and the teachers will warn each other that a kid coming is a trouble, right? So parents are very, very wary from preschool upwards of getting their kids tested, all right? So, estimated 7% right now, and genetics and environmental pollution and factors all seem to play a role in the development of ADHD. Symptoms of children who, and there's a spectrum now, so they've got, you know, they have ADHD, they also just have ADD, which without the hyperactivity, so there's slightly different versions of attention deficit now. They tend to be somewhat aggressive, which of course inattention and aggressiveness means that often they're causing disruptions in the class. If it's ADHD, they're very hyperactive. They find it very hard to sit still. They're very impulsive in a way that is not appropriate. So you see that with adults who are ADHD as well as children, right? They know they're not supposed to do something. Wyatt, right? Classic. Wyatt. He knows he's not, but he can't stop himself. Right? And so these behaviors lead to some social problems often. They tend to have poor academic performance. They score poorly because of the way we run exams and testing. They don't tend to test very well in school. Less than 5% of people diagnosed ADHD get a college degree versus the typical population, which is quite a lot higher than that, right? It's more common for boys than girls by about 3 times as much. About 50% of people with ADHD also have motor coordination issues. So they're quite clumsy. Their coordination is not very good. So they don't run very well, they don't pick their feet up enough perhaps. And again, why it's a good example of someone that doesn't have that, right? He's very skilled at moving. But a lot of children with ADHD struggle with PE and movement behaviors because they're not very well in control. So what happens when you have ADHD is that areas of the brain that are responsible for cognitive function tend to have delayed development. So they can be 2 to 3 years behind their peer group on cognitive functioning. So again, because the way we organize school, that causes problems because they're not held back 2 years because they're that age. So they're in a class with their peer group, but because that's their age, but cognitively they're 2 years behind everybody in the class. So you've got to feel bad for the child who has the problem. It's bad for the other kids in class because they're disruptive. It makes the teacher's life hell, right? It's very problematical. When you exercise, you release adrenaline, norepinephrine, right? Epinephrine, other catecholamines that increase blood flow to the brain. And so we see increased blood flow to these areas that are a little delayed. So exercising helps. It may enhance the development of the area of the brain that is delayed. So there's lots of research looking at that right now. We don't quite understand how that works. Often they'll use some kind of psychostimulant, so Ritalin or Adderall. Right? They'll put children on those kinds of drug therapies. The problem with psychostimulants is because it's a stimulant, of course we see increases in heart rate, increases in cardiac output, tends to increase blood pressure. All of these put the individual at risk for cardiovascular disease. So there's a trade-off. Can I control my behavior using the drug? Is it worth controlling the behavior? Then I would need to exercise more to decrease the risk that the drug uses. Right? So it's problematical. Exercise does seem to improve disruptive symptoms for many children. It helps them pay attention better in class if they're able to exercise before class or before an important exam. Yoga and Tai Chi have been used quite successfully with children with ADHD, and there's a lot of work looking at that. So there might be long-term benefits of trying to use exercise to help rather than go automatically to the Ritalin or the Adderall. But again, it's highly individual. I would say that our friend at the childcare centre needs meds. Right? He's highly active. He's very skilled at moving. His behavior is off the wall. Off the wall. He's going to do very poorly when he goes to school. So I'm not a clinician though, so I don't know, right? I'm just saying. I wouldn't be surprised if it would help.
What, I mean, aren't they just kids? Like, they're
No.
just kids.
No,
Boys
he's
looking
not
boys.
just a kid. His behavior is not typical.
Yeah, I mean, but.
Not typical.
See, but if you put on medication, then like, you're basically hindering, you know, their life like 10 years from now.
But if you don't put them on medication, you can be injuring their life because they're going to do poorly in school. They won't make friends well. They'll be an outcast in school, right? They're going to do poorly. Then they can't pass their high school exam. What kind of job are they going to get?
I don't think that's true. Because I've been in school with kids who have stuff like this, and like they had plenty of friends. Like yeah, they didn't do as well on tests, but they had plenty of friends. People talk to
Yeah, I
them.
mean, that's special.
Yeah, I think it's.
I read last year that there's a higher incidence of ADHD here in the U.S. than all over the world. And they suggested that was because of how people are starting to turn up their kids now. What do you think about that?
Yeah.
What was the last one?
Wait, how they
Yeah, I
doing
know
this?
some.
They don't discipline their kids at all.
Oh,
Some people are
True.
Well, but ADHD is a clinical diagnosis, so I would struggle with how you discipline the children being a. That might be creating more behavioral problems among children, but behavioral problems aren't the same as ADHD. I mean, ADHD is a clinical problem in the cognitive area of the brain.
Do you think it's being overdiagnosed then? Because
I think it might be being overdiagnosed, yes.
Yeah.
Yeah, that wouldn't surprise me at all. I think it's an easy cop-out, and bumming the kids on meds is an easy way to get them under control. Absolutely, I don't disagree with that at all.
Yeah, that's how I was gonna, yes,
But that's not the same, that's a different problem.
So what would be a better way to diagnose it then?
I'm not a specialist in this area. I have some colleagues who are. They have a clinical set of tests and a range of behaviors, and they can do imaging issues to look at the area of the brain that they think is related to the problem. So they have a very distinct set of tests to diagnose someone with ADHD properly.
But you can tell when a child is on ADHD. And my nephew's ADHD.
Yeah.
And when you give him his medicine, he's perfectly fine. But by 3 o'clock, it's worn off and he's a crazy maniac.
Yeah.
There's been instances when he's in class, or not in class, like in school, where they tell us not to give him his medicine because he acts better when he's got the sports, when he's playing the sports. But he's crazier when he doesn't. And he can physically tell you if he hasn't had his
Has his
medicine.
meds. He can
Like,
feel the
you can
difference.
feel it, and we ask him, do you have your medicine? Did you take it? And he goes, no. Nice. And you can tell that difference, especially even during the weekends,
Yeah.
when he doesn't get that.
So will the solution just be putting PE back in the curriculum now?
I think the solution to a lot of problems is putting PE back into the curriculum, but I'm biased.
Yeah, same thing with love, huh?
Not only should it be in the curriculum, it should be mandatory every day.
Love wins it all, Dr. Love.
But, you know, I don't get to vote, so.
What about love? What about love, Dr. Walker?
So, just be aware if you're gonna work with athletes, that some of the meds that an ADHD athlete may take are banned. So that means that you have to have the paperwork in order, so that if you test positive, there's no repercussions for testing positive. So you've got to be careful and make sure that all your paperwork is up to date and that you've got your diagnosis from your clinician and all those ideas. Some of the other problems, as I say, the cardiovascular issues related with these stimulants are well documented. I haven't heard of this idea before, blunted pain response, although I don't know if they're not taking the meds I think they have a blunted pain. I mean, they're so crazy, they don't care if they hurt themselves. I mean, they almost don't feel it because they're so hyper. Higher core temperatures that can lead to overheating, hypothermia. That one will probably be really important. Again, if you're going to work with athletes or with PE students in an environment where it gets very, very hot, if you've got a child that you know is on these meds, you need to keep an eye on them if you're doing PE or training in the heat, because they're going to overheat quicker than everybody else. Okay. This table is in your book. These are some of the official symptoms. Sometimes are a little tricky when you're a teacher in front of a class. So this table just gives you some more, I think, user-friendly ways of identifying symptoms that you can pick up on with the children. Increased risk-taking, difficulty waiting for their turn. They don't do that. They just barge into the front. So
Yes, ma'am.